but it was treating my vagus on a consistent basis, went from having a positive ANA to a normal negative ANA. That is incredible.
From a medical standpoint, it's impossible because they don't have a way to treat the vagus nerve. It's hello.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
I'm great.
Okay, we could just stop there.
All right, podcast.
Yeah, and we're good. It's just been, and I feel like I should knock on wood or wait for lightning, but the universe just paid me a solid with a bunch of new, very clearly defined patients the last 10 days. And I am just expressing my gratitude for just nerve pain.
Okay, there you go. Expressing your gratitude for
just nerve pain.
Oh.
And I'm putting this in bunny ears because I think back 15, 20 years ago when these people would have walked in and I would have had the same irritation that they are. But I'm like, really? That's it? It's just some burning, tingling, and like C7? That's it? Oh, okay.
Yeah. Yeah, it's like busy. Yesterday, I had one patient I was treating, and this time her sister came with her. They're both tennis players. And the first girl, it was a maintenance thing. It's okay. What I've done hasn't helped. So mom bought a knee brace and they figured out she's hypermobile. So they're going to get her, because there's a new paper that's out on hypermobility that says it's about that it can be fixed with methylfolate. And it's so try this for a month. And then the sister was there and she said, oh, I need to see you sometime because I was working with this trainer and he had me hit the bar really hard and my shoulder hurts here and here. And I said, it's just your shoulder? We've got 45 minutes. I can fix your shoulder. And we did. Subscap, pec minor, supraspinatus bursa, and 124 and 77 because he tore the posterior muscles because the subscap, and she'd had her subscap worked on by somebody manually, physical therapist, and she said, oh God, you're not going to put your fingers in there. And I said, no, trust me. And it was like literally 45 minutes. She's giggling and she's going to Alabama for a tournament and I get to play on a clay court and my shoulder doesn't hurt. And I said, if you like tennis that much, you need a trainer. They're playing tennis in high school. They have random coaches, but they don't have a team. I said, you need a trainer because your coach didn't tell you that what you need to do is strengthen the posterior muscles. Oh, she said, I do biceps and I do pecs and I have Kim Pittis in my ear telling me you have to stabilize it from the back. And at her age, the coach has her doing everything from the shoulder. No, all your power comes from your butt.
Yeah.
Excuse me? This muscle here goes around to your low back. It's called your lats. And you wind it and unwind it. And that's where the power comes from. It doesn't come from your pecs. And this was all like news. And I said, if you're serious about playing tennis and you want to go to college and playing tennis, you need to spend 3 days a week in the gym and 2 or 3 days a week playing tennis on a backboard. Slow, light form. And I had your voice in my ear the whole time, you and Charles Poliquin.
Oh,
And
those are two great voices to have simultaneously, and
it really was, but
like
it's
dueling pianos.
the concept of form and stabilization for the shoulder. We're the only ones that think that way.
I think I totally agree with you. The shoulder is such a unique joint that I don't even want to call it a joint, because
It's a complex.
it is like it would never stay in place without the rotator cuff holding it there. So it is completely reliant on proprioception.
And muscle balance.
Yeah, and muscle balance can occur truly without proprioception. So that concept of stabilizing, co-contraction, slow, letting that loop continually go back to where the body is in space, doing things that they can't see, catching a ball overhead, catching a ball behind there. These are all little tiny drills that need to be incorporated, especially with a sport like tennis.
And showing her, having her feel what it's like. Like, we were out of time, so I had to do it. But feel that muscle? That's the lower trapezius. Put your hand on my side. That's the serratus. Those are the muscles you strengthen.
Yeah.
And you watch videos of Serena Williams. She doesn't use her shoulder. She uses her butt.
Totally. And Leafa just asked about golf. So it's going to be the same thing. Those rotational sports. We joke, obviously, I treat a lot of hockey players. I'm from Canada. That's where I cut my teeth with all my sports rehab. And there's the joke that hockey players have these big butts. And it's not just about skating, it's about the rotation and the power that doing a shot all comes from the pelvis. And it doesn't come from the shoulder, it doesn't come from the trunk. That's just the follow through mechanism. I am very pelvic centric, anyways. I do believe the corrections happen above and below. So I will always start there, just like you're very neurocentric. But it's funny, both of us will start with different starting points, and we typically end up getting to the same conclusion. Our posterior chains are weaker than our anterior chains. We're very anterior dominant right now. And
What's up with that?
Everything we do is in front. Like, you're in front of me, my coffee's in front of me, my phone's going to be in front of me, cooking is in front of me. And when we think about safety patterns, right? Fetal position is safe. Like, we're here to protect our organs. So we like to be in a ball. However, our posterior chain is where all that power and stabilization comes from. So we need, because we spend so much more time sitting than we ever have, we need to just do a little extra homework, tennis, golf, or not, on that activation of the posterior chain in those safe patterns.
And as for leave, that's tennis power. Golf, tennis, and golf are the most biomechanically insane sports. Rotation, upper body, and it's like,
I might add hockey to your list, because then you're going to put large men on really thin blades and make them scream up and down an ice surface as fast
yeah,
as
at 30 miles an hour, and then run into each other at crash and burn. The difference between competence and excellence, even in an amateur, is get into the gym and strengthen the stabilizers. And then when you're practicing your sport, focus on form, at least for the first 10 to 20 minutes of the workout, so that it's slow, so that you get it in muscle memory, so it goes in the spinal cord, so it goes to, because that's what I did with her after the shoulder. Moving it passively, even, she got nervous right about here. You could see it in her face. So I just switched to 40 and 89 and moved the shoulder passively, and then had her move it actively and say, oh, that's easy.
Yeah.
And then I did 81 and 84. So I'm neurocentric, but after you make such huge changes in the periphery, in any sport, you have to.
And even in no sport, even
Yeah.
just for activities of daily living. I think of putting a cup or a plate or a book back up onto a shelf. So in the sports/rehab class, we talk about doing, after you tear apart the shoulder and basically do the supine cervical and supine shoulder treatment, we talk about what patterning needs to be in place. And so I love doing planks and modified planks. You can do a plank/push up against the wall. It doesn't have to be weight bearing. It doesn't have to be, there's so many modifications, but it's just that safety of that scapular co-contraction that has to happen before we can ever expect the GH joint to behave.
And this is a 16-year-old.
Right.
The bones aren't connected to the cartilaginous plate. Everything floats.
Yeah.
So the bone isn't stable, the muscles aren't stable. I said, so you do not do push-ups. You put your hands on the wall here and do this. And you could see her get it.
Yeah.
It was.
That's the great thing about youth, is they can make those neuroplastic connections so much faster. And so a lot of the times we as practitioners have to stand behind the patient and squeeze the shoulder blades and poke the back and say, this is where I want you to contract. And then they want to do the traps. No, not the trap. Retract, depress, downward rotation. These are patterns that like a lot of us just don't do in nature. We let our traps float up to our ears and we do all these accessory motions to get through the day. So this is what I love to do, is to just break down patterns and watch it take off with the support of using FSM and using 40 and 89 in the beginning, and then doing all the loading that we do in the sports course. And just, it's not taking over, it's just like supporting the nervous system to find the contraction, smooth out the contraction, get the quality of the motion happening, and do that safely and do that with confidence, because that's when it sticks.
I wish, if I had a wish list, we do the 2-day practicum in Troutdale
Yes.
on Saturday, Sunday. In a perfect world, we would do the 2-day practicum Thursday and Friday, or sorry, Friday and Saturday, and then have the sports rehab Sunday and Monday. So it's a 4-day commitment, but there's no point in being able to fix the shoulder. I fixed a partial thickness tear in the teres, strain in the supraspinatus. He strained the biceps tendon, aggravated the heck out of the supraspinatus bursa, and her pec minor was 124 and 77, and then scarring the nerve, artery, and vein to be able to drop it back. So we teach all that in the 2-day practicum, but to have you come in 2 days later, this is the first time I've mentioned this to you or Kevin, because it just dropped into my mind.
I love it because it really does make so much sense, because people need that time to touch and feel and play with the rehab. You need to feel taking something apart and feeling the smush and gaining that range of motion. However, I do feel very strongly about returning that strength, that coordination, the co-contraction, the proprioception. I think that is really integral to do following a rehab treatment if you want those gains to last. And I think any failure that I've ever had where it was a success for the time in the clinic, but then they call you or they come back a week later and they're like, yeah, it didn't hold. And it's okay, we missed something in that proprioceptive mark. Why?
Well, strengthening and stabilizing is a thing. It has to be done.
Yeah.
We're talking about horseback riding, but the lats.
Mm.
So when you're riding dressage, they want your thumbs up and your hands close together. That means you're not allowed to use your lats for your arms. Use your lats for your low back, you're very pelvic centric, but you have to keep your upper body relaxed.
Yeah.
That's when you're on a well-trained, schooled horse doing an exercise that's safe and balanced and everything's fine. When I'm on a horse that's trying to kill me, which I was in my 20s, you are allowed to have puppy dog hands
Yeah.
because that's where all the power comes.
Yeah.
You contract your lats when your arms are internally rotated and you're using your low back so that's the difference. Your arms are coordinated and soft here, and then power comes from your lats. Whoever designed the shoulder decided that it needed to be connected firmly and thoroughly to the low back.
Yeah, there are many design flaws with the shoulder, but we have to work with what we have, just like anything. But it's knowing, I never thought I had to learn anatomy as well as I did until I started using FSM, but it's also kinesiology and biomechanics because that is where you're taking the form, you're taking the shape, you're thinking about what does this muscle look like and what is its neighbors and what does it affect? And if this muscle is inhibited, then now what is happening? And I think that's what helps you not just solve the case. It was like those 7 S's that we came up with the crime scene, but it's asking the neighbors about what did you see last night? It's asking the lower trap. How involved are you with the lat? What is your relationship right now?
And what is your relationship with the serratus?
Yeah.
And yeah, exactly.
So
sorry, lane change.
Love it.
You know how I have always said, if you listen to the patient, they will tell you what's wrong with them.
Yeah.
This week, I found out that you can't always listen to the patient because sometimes the patient is wrong. She fell off a ladder. She's 71. She fell off a ladder 3 years ago and hit her fibula and scraped down the peroneal nerve and the tibial nerve, like the whole lower extremity was just bruised all to pieces, nerve traction injuries. And MDs had done nerve conduction studies, and they said the peroneal nerves, both the superficial and deep, have slowing. There's a problem. She also has three L3, 4, 4, 5, and 5S1. 3, 4, and 4, 5 are fused. 5S1 has a disc bulge with compression. So she's got general nerve pain in her legs. And then, so the first day, I believed her. I ran from the knee to the toes, inflammation in the nerve, and then scarring in the nerve while I tried to freak, because she said the nerve is scarred. That's what the patient told me. Nerve is scarred. So I did all the scarring, didn't change it. Comes back the next day. I get Netter out. When you look at the lower leg, you have the gastroc, you have the soleus, you have the tib posterior, you have the tib anterior, and they all have connective tissue attachments. So from her knee so I'm treating the nerve from her low back to her foot because she has L5 and S1 are nasty. And then I treated torn and broken in the connective tissue for 2 hours because as it started, it was, oh, that doesn't hurt as much. Oh, but now it hurts here. Yeah, I haven't gotten it yet. 2 hours. She got up, she was pain-free. It was tendinopathies that made the muscles tight and the muscles pulled on the nerves. Yes, the nerves were scarred to the muscles, but the muscles were creating nerve traction injuries because the connective tissue had partial tears in it. That made the muscles tight. That made the little bit of bruising that was between the nerve and the muscle create a nerve traction to injury every time she walked. So the key was to get the muscle to relax.
Yeah.
And they'd already done all this abusive stuff to her lower leg. And trigger point injection, this was the other clue. Trigger point injections helped, took the pain away for 2 weeks. Trigger point injections in the muscle? Yeah, it was just the muscle. But she's telling me it's scarring in the nerve. What if it is just the muscle? What causes trigger points in the muscle that go away temporarily and then come back? Tendonitis. There's that whole section in the core, tendonitis. So I treated the flat tendons and it worked. It was like so cool.
Yeah, there's a slide in the sports course that I have. Do you start deep and go superficial or superficial deep? And then the next slide is yes, because you can't just, it's not just one versus the other. Sometimes the muscles are reacting to something deeper, like a nerve or a joint or disc or something. And sometimes, like the mechanism that you're talking about, the fascia and the nerve create tightness that pull on the nerve that creates the pain. And so you have to listen to the patient, and you did listen. And I think that's what made you go to, okay, if trigger point injections helped, there's something there, because that is when the tissue is all gummed up. And then if that gets released and it feels better, there's your mechanism.
Exactly. And there's one other thing that I learned from this patient Monday.
Yes.
And that was she came with all of her imaging. She has had amazing amounts of care.
Yeah.
And her C-spine MRI has disc bulges at 3, 4, 4, no, 4, 5, 5, 6, and 6, 7. 2 of which flatten the cord. They don't just touch the thecal sac. When you look at the cross sections, there's actually a dent in the cord. And this is a surgical neck.
Yeah.
The MRI is a surgical neck. Then I did the physical exam. Her nerve, she had a little bit of nerve ickiness in her hands. She had a little bit of tightness in her legs, so that was an 81 and 10. But she had normal reflexes in the upper. She had a +3 knee reflex, no clonus in the ankle. Babinski was negative. And what I told her was, your MRI says you are flat out surgical. If I just saw this MRI, I'd say, don't come and see me. Go find a neurosurgeon and get this done, and then come back and we'll clean up the mess. What I had to tell her was, your physical exam is not surgical.
Yeah.
Your MRI is surgical. It was very confusing because I was sure that a Babinski would be positive.
Yeah. Yeah. And you know, that goes to show you sometimes the imaging, like Charlie Weingroff, when we had him on, did this really great sort of visual of these bubbles that intertwined. And you'll have the bubble of the patient complaint, and you have the bubble of the imaging. And sometimes it coincides, but sometimes it doesn't.
You have the patient complaint, you have the imaging, and the third part of that place where they intersect is the physical exam.
And that was what he was saying. Like, you still, that's why it is so imperative that you do it, because I have had so many patients that I refer to this wonderful orthopedic surgeon that I love, that he agreed to come and speak about PRP and all the biologics at the advance. He's so excited because he's seeing people that I send him the history, I send him the imaging. And there's been a couple times where he expected them to be wheeled in with a walker or a wheelchair, and they come strolling in, and he's like, how are you moving this.
How are you walking?
Exactly.
Why aren't you dead?
And they're like, I've been seeing Kim. It's, keep seeing Kim. You will need a hip replacement at some point, but let's just buy some more time and keep doing what we're doing. That is one of my most exciting things, is when people get frustrated, right? Sometimes they don't see the progression, but I'll send them to my colleague and he'll say, maybe you don't feel like you're progressing, but you're not degenerating. You're not going down. You actually are improving, because based on your imaging, like, you shouldn't be here. You should be here. So I think that's an important part that we tell our maintenance patients or the chronic things, is like, there's still so much we can do and it could be so much worse.
Yeah. What's his name?
Mossy Reynolds is his first name.
Ah,
And that Dr. Reynolds, Rey, and then Reynolds. Yeah.
Reynolds, MD, Kim, because I have to start writing down and making phone calls.
I'll connect us. I'll connect you with him. I said, I go, the advanced is so much fun. You're going to be very well fed. And he just needs a lot of notice, just like all the busy folks. So I said,
we're almost a year out, and I just got back from Phoenix, and the mold in the Santan room where we have the breakouts on the core, that has been completely remediated, and they checked the ballroom and it's clear. So mold sensitive patients can come, and this is the one and only 4-day advanced ever.
I love it.
Yeah, it's gonna be so much fun.
I cannot wait. I have to jump on one of these questions because I have so much to share about it, but I'll let you talk first. Julian's question about his knee. He's doing Qigong and he stands with the knee slightly bent for about 30 minutes without movement. So it's very slow movement, but the knees are slightly bent. He has minor pain in the knee, feeling like it's behind the kneecap. He's saying tendon. He tried torn and broken, increasing vitality and secretions to the ligament, connective tissue, tendon, and fascia. Then Denise popped in with the nerve. I respectfully disagree with kind of everything. So I'll let you start.
That's the cartilage. When you have your knee bent, the kneecap is in a groove. There's cartilage on the inside of the kneecap. There's a little bit of cartilage on the femur, nothing much on the tibial plateau. But when your knee is bent, the quadriceps tendon is tight. And if you don't move it, the cartilage is like a very stiff sponge.
Yeah, great analogy.
You don't move it for 30 minutes and you get creep. You did treat 124 and 77, so you've got the quadriceps tendon that could have gotten cranky, but the quadriceps tendon doesn't create pain behind the kneecap.
No.
The only thing back there is cartilage.
And the fat pads. The fat pads
yes,
are grossly neglected, and they're imperative. If you even look up Hoffa's syndrome, this is pain where people think it's the kneecap. It gets misdiagnosed for patellofemoral syndrome. The fat pads, there's 4 of them that are all within the knee, behind the knee. And so when I think of something static like that, first thing I think about is cartilage. The next thing I think about is the fat pad. So treating sclerosis in the fat pad, so 397, that's going to be, we see that effect so important with the like ACL, MCL, meniscal repairs. The fat pad just gets congested and
inflamed
and sclerosed, just like what fascia and muscle can do. So I would start for sure with the cartilage, and also don't forget about the fat pads.
And the bursa. There's 13 bursas in the knee.
Yeah.
And there's just, 2 really big ones, one above the kneecap and one below the kneecap.
Yeah.
And if that tendon is squashing them for 30 minutes, they might have an opinion about that.
So hopefully, Julian, you heard that. If not, I can email it to you because I'm very passionate about the knee. I've had a lot of experience lately with But yeah, the fat pad was one that, like I said, we see it and we learn about it, but then we forget that we can treat it. It's just like the cord and the dura. We know about it, but we have to remember we can treat these structures.
Yeah.
And adipose is,
And as much as I love Netter, when you look at Netter's diagram of the knee, there's no fat pad
no,
and there's no bursa.
no.
And there's 13 of them.
Yeah,
And then the real killer is the pelvis. There's 18 in the
yeah,
pelvis.
yeah,
So look those up separately.
yeah.
And with FSM, it makes a difference.
Yes, absolutely. So
It's
exciting.
all right.
Since we're doing questions, let's get at a couple of them. Can you
Sure.
explain FSM combined with watching blood sugar helps insulin resistance?
No.
Okay.
Next question.
Next question.
Yeah.
Thank you.
Insulin
'Cause I'm
resistance.
like, this is great. Let's hear this.
No, sorry. Insulin resistance is where the adipose becomes resistant to the effects of insulin that want to take sugar out of the adipose when you need it.
Yeah.
And instead, the insulin can't get the energy out of the adipose. And so the vagus nerve says, I don't know what your problem is, but I need sugar to run my brain and my muscles. So would you eat something, please? So you eat more calories than you probably need. And it's how it all goes together. How do you reduce insulin resistance? The FSM protocol works because it reduces inflammation and toxicity in the adipose, but so does exercise. Go for a walk.
Yeah.
Some patients would rather have a root canal than take a 15, 20-minute walk after dinner.
Yeah, it's true.
And it's like the studies show that exercising after a meal, like light exercise, go for a walk for 20 minutes after dinner.
Yeah.
Okay, you tell the patient that. Watch their eyes glaze over.
Yeah.
Make them keep a diary of that.
Yeah. She just said there's a insulin resistance program on the custom care. That's why she was asking. So
It worked great, especially in the beginning when we first started using it. And I don't know if the kinds of toxins we're exposed to now are different than they were in 2000 when that program was developed. But for me, it got me so far.
Yeah.
But it is overcome by the neurologic part of insulin and leptin resistance.
Yeah.
And stress and the vagus. So there's a neuroendocrine reason why people have an appetite for food and or carbohydrates that is unreasonable or unhealthy. And some of it's just habit and or culture.
Sure.
You can go to countries in this world where the incidence of obesity is 5 to 7%.
Yeah.
In the US, it's 60%.
Yeah. 65%, something like that now. Yeah.
You walk into a grocery store and there's just literally, there are multiple aisles where there's no thing that you can eat that's good for you.
It's true. We used to say the personal training world, I want you just to shop on the perimeter of the grocery store. That's it. People are like, what? I'm like, if you think about what's on the perimeter, like no sugary, processed, chemically altered foods live in the middle of the grocery store.
Produce aisle,
Yeah.
dairy aisle,
Yeah.
what
Meat.
else on the other meal? Yep, the meat aisle. Yeah.
And then you've got your bread. So bread, I have to bypass that unless I'm just getting my gluten-free bread. But yeah, that's just what we have to do. So yeah, it's not a magic wand, unfortunately. But okay. Oh, Kevin, somebody just asked about the dates for the advance. I just thought I saw them. Maybe Kevin put it. Yes. So the date for the advance, March 19th to 22nd.
So 19, 20, 21, and 22, and I'm just going to be lecturing in the morning. The first 2 days we've done a number of times. So the first 2 days we'll have breakout speakers in the morning. Kim will be one of them. I just
Always count on me.
no. And then probably David Musnick or Bill Clearfield. And then I'll lecture all 4 mornings. The second 2 days of the advance will be stuff you haven't ever heard
Yeah.
because I never get that far.
Yay.
And more how to think about it, processing stuff. You have conditions, you have tissues, you have internet literature searches, and you have functional medicine, anatomy, physiology, Goodman and Gilman. You have all these resources that connect the dots. And I'll give you hints, but I can't. So it's the whole purpose is teach you how to think with the channel A's that we have, the channel B's that we have, and it'll be fun. And then the afternoons we'll have, oh, I'm so excited. Juliana Mortenson's coming back. Oh, we just remember last week we have a scleroderma paper published.
Yes.
We just have our first paper case report published on Ehlers-Danlos
Yes.
for mobility. Carolyn Perry published in British Journal of some peer-reviewed journal. So Carolyn Perry has done it again.
Yay.
Oh, she's coming.
Amazing. Yeah, the more we can get out there, the better. And a couple years ago, I want to say we had somebody present on how to write a case report, and it was
Candace Elliott.
Candace, that's right. Yes. If you're doing chart notes the way that you should be, you can throw it together and make a case report.
Candace's life has gotten busy with all the fires and all of the things that have happened in her personal life. So I have her slides, and it gives you a lot of detail.
Yeah.
Karen Perry, the first paper she wrote, took a lot of editing. The second paper, almost none. I spent 10 minutes on it. First paper, Candace and I spent hours
going back and forth.
Yeah. And once you understand how to be concise and efficient in how you say what you want to say, reading what the journal wants in terms of a format.
Yeah.
It's second one is much easier. The first one is like writing your first high school term paper, but after that it's easy. So I'll use Candace's slides and see if I can slip myself in for how to write a case report, because that's how we survive. And the next piece is like what Walter did, which is a collected case report, and actually get statistics on a body of people. Doing a single case report in hypermobility is impressive, but less powerful than doing a collected case report with 10 or 20. Yeah. Where the p-value has 3 zeros. We can do this.
Yeah. Yes. Yes, we can.
Yes, we can. There we go.
Right. One more question, or a couple more actually. Tracy, is there a reason why someone would feel tightness or stiffness in their elbow joint and forearm after treating for edema in the bone marrow? So she was treating the olecranon and posterior medial humerus and muscle, flexor carpi ulnaris. Edema was found on the MRI. Could it be lymphatic congestion, nowhere further fluid to go? I will jump in quickly because we were talking about this at this Newport Beach conference. We're talking about bone marrow edema, and with shoulder dislocations, it's frequently seen on the MRI that there's bone marrow edema. Treating 14 on A, which is edema, and bone marrow, I believe, is like 238 on B, was the only frequency that helped with the pain that somebody had. Even though treating the nerve and treating torn and broken and all the things, that was helpful. But the osteopaths that I was talking about with bone marrow edema, we're talking about fluid, and that gets moved in and out, yes, with the lymphatics, but a lot of the osteopathic techniques that are used are for fascia. They believe the fascia becomes congested. So we have a frequency for congestion, we have a frequency for fascia. So that is something that you could try. It's only fresh on my head because they were all ranting and raving about these types of pumping motions that you can do for the fascia when there's bone marrow edema.
And the other thing is, the first thing that occurs to me is when you hit your elbow hard enough to cause bone marrow edema, is it possible to hit your elbow hard enough to cause bone marrow edema without causing road rash or bruising inside that would adhere the C7 nerve root in the groove?
Yeah.
Or 124 and 77.
Totally.
These are all connective tissue. There's no round tendons in the elbow.
Yeah.
So how treating it's like the lady with the MRI.
Yeah.
If you're treating the MRI that shows bone marrow edema, or are you treating what you feel? Yes, the bone marrow edema is there.
Yeah.
But the imaging was done 3 months ago. The edema is still there. Connective tissue, all of the work that people have been doing involved doing this to the elbow.
Yeah.
What's going to happen to the connective tissue attachments
Of course.
to the periosteum? So and what the question says is stiffness. Why would they feel tightness or stiffness in the elbow joint and forearm, the muscles,
Yeah.
after treating for edema in the bone marrow?
Yeah.
So you treat the edema in the bone marrow and the muscles relax, but that puts more strain on the tendon, right? Is that
Yeah.
possible?
Yeah. For sure. What I'm reading, could it be lymphatic congestion, nowhere for the fluid to go? Maybe, because when I would treat for this, if this is my patient, I'm not just slapping FSM on them and leaving the room. Like I am doing I am doing those types of pumping techniques. Elbow comes up. Whenever there's edema or swelling, I also like to use elevation let's work with the body, let's work with the blood flow. So for sure, I would also treat the soft tissue structures because, like you said, the mechanism, like, how did you get bone marrow edema? What was the mechanism of the injury? Because there's other pieces in play. You can't just have bone marrow edema without having connective tissue damage.
Yeah. And what position was your elbow in when you landed on it?
The baseball pitcher she just wrote. So,
Oh,
so again, yeah, going back to the tendon, this is Wolf's Law. Like this is, yeah.
and how old is the baseball pitcher?
Yeah.
What did coach do? Was it a new kind of pitch? Any baseball pitcher, it's almost always a tendinopathy involved
For
or
sure.
a nerve that doesn't slide.
Yeah. But in any event, like I would still positionally place them in an area where you're standing behind their head and their arm is up. So all the treatment that you're doing is going towards the heart and you're just working with circulation anyways. I would just make sure that would be really important in my mind.
I agree.
Anonymous, can FSM address fourth cranial nerve palsy with no trauma or infection? Their idea was 4396 or 49396. Anything else?
So the fourth cranial nerve controls only the superior oblique muscle of the eye, and it does vertical and rotational eye movements, resulting in double vision and other visual disturbances. No trauma or infection. What imaging have they had? What is their vestibular exam like? I think that's something that's going to be in the advance this year. I found a list of George's cranial nerve numbers. Some make sense, some don't, some work, some haven't, but I'll put them out there and I'll put them on the laminate. I have a whole page of George things. Have they had a brain MRI? Fourth cranial nerve comes out at the top of the anterior surface of the pons.
Yeah.
And goes, this way from right about here. Yes, and Alf is right. Viral infection that does not have any signs of infection. So you can get a viral infection of your vestibular nerve. I had a patient, a friend with a viral infection that took out one of the 4 branches of the vestibular part of the 8th cranial nerve. So the 8th cranial nerve splits into the auditory part and the vestibular part, and then the vestibular part has 4 or 5 branches. And the virus came along and just attacked one of the 4 branches and killed it. It was done.
Right.
She was in bed for 3 months. She couldn't get up. She was so dizzy. So trochlear nerve viral infection is not a bad bet. And then the question is, how do we get it back? Can you treat it? If we have the possibility that this frequency for the 4th cranial nerve is correct, and we don't have enough mileage to know. So it definitely still has a little eye on it. So just because it doesn't work doesn't mean that you guess, but
right.
160 is malignant virus. And then I guess you could try any of the COVID viruses, 38, 41, 44, 56, 160, 189.
Yeah.
And then that 4th cranial nerve frequency that's experimental. But then remember that the 4th cranial nerve comes out of the pons. So if the frequency for the cranial nerve doesn't work, go back to, they all come either out of the pons or out of the medulla.
Yeah.
So we know we know for sure the pons works. I don't know if that thought process is going to extend.
I think that's when there's something happening with the nerve and it's not 40. What else could it be? And so many things, but jumping in, talking about a viral infection.
It's good.
For sure. Yeah, what kind of, when you say there is no trauma or infection, how do you know? How do you know?
Yeah, what is it? How many of you have had viral infections that just didn't show up in imaging?
Yeah. Yeah. Or that were just troublemaking enough, but not enough that you really remembered it or it affected you so much. There's so many things. How do you know?
And it is really interesting. There's no other profession.
Yeah.
This is in air quotes profession because we have every possible clinical profession amongst us.
Yeah.
But there's no other profession where they actually ask the questions that we ask. Because if they can't fix it with steroids, acyclovir, gabapentin, or Lyrica, they don't know what to do with it.
Yeah.
Those are their tools. And she has to have an MRI of her brain to make sure there's not a tumor in a particular portion of the pons where the 4th cranial nerve comes out for just one side. It's okay. That's all I can think of.
Yeah, I would agree. I think there's so many avenues that you could go down. I was doing an online consult right before we had jumped on, and there are all these stories of, I don't know why, but I get an upset stomach with this. And I don't know why, but after my upset stomach, I have muscle weakness here. And like you start thinking about autoimmune and gut issues and all the things. And I said, for now, let's just get your vagus working. Sometimes we get so overwhelmed with so many channels that we could chase, right? And I'm violently writing all these things down, gut, this, adrenal, blah, 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 blah. And it's just, okay, what do we know for sure? If our vagus nerve is taking care of us, all these little things are not going to be as bad. I'm not saying it's a slam dunk. All we need to do is treat the vagus nerve and vagal tone and it all disappears. But so many of us just need that vagal support. I was even using my own case of having all these little autoimmune markers and this positive ANA and kind of freaking out and just making some changes with my diet. I'm pretty healthy, but it was treating my vagus on a consistent basis, went from having a positive ANA to a normal negative ANA. That is incredible.
From a medical standpoint, it's impossible because they don't have a way to treat the vagus nerve. It's hello. Yeah.
But like and then that's when I hear your voice all the time. Just let the vagus do its job. So like you're simplifying it, let the vagus do its job. I'm saying just put the midbrain in a corner with a lollipop and a pillow and give it a timeout. Amygdala needs like serious space right now. And we're maybe oversimplifying, but like
we have data on 40 and 116.
yes.
And the last practicum that we did, or maybe it was the last 5 days, I said, we have data on this. It's huge. And I don't ever run it on myself anymore. And
Yeah.
they look at me like I'm green or a traitor or something. And it's, I let my vagus nerve decide how much inflammation I need. You need a certain amount.
Yeah.
And I don't know how much that is. If I smash my finger with a hammer, I can run 40 and 116 and get the swelling and the pain down. And I can run hemorrhage. Okay, I'll do that. But on a general day-to-day basis, I treat the vagus, and I just went to custom care and I put brain and vagus at the top. And she said, how often should we run it? And I said, I run it every day. And she said, what? Why? I said, do you watch the news?
Yeah.
I said, hello.
Yeah, just live in the world right now.
Yeah.
But and that, what you just said, we need a certain amount of inflammation. And everybody's heard me talking about we're not icing, we're using heat. When I was at Newport Beach with all these really great minds, that was one of the very common themes was we need inflammation. We need inflammation to heal. We need inflammation to digest our food. We need inflammation to overcome illnesses, stress. Like we need a certain amount. It's when the inflammation goes out of control, when our knee goes from a little bit swollen to crazy swollen. I had a triathlete the other day that his knee gets inflamed after he runs. I'm like, and he's, what do you mean? So it gets inflamed. I'm like, does the inflammation go away? He's like, yeah, after about an hour. I'm like, okay, great. Macrophages are cleaning up the debris that you've been hammering on your knee for the past 25 years. You're strong, you're functional. It's okay. And nobody's ever really told me that it's okay before.
It's doing what it gets paid to do.
They're like, it was funny. I had this conversation with Diana Cross. I think of macrophages as working dogs, right? I have a German Shepherd. She is a working dog. She goes a little crazy if she doesn't get to protect the house and smell for things and do obedience. She needs a job. Macrophages need jobs. We need to let them do their thing.
Right. And they also have to understand, like your German Shepherd, there are rules about what sorts of things you attack. You do not attack the mailman. No, the mailman is our friend. So the macrophages are allowed to do this, but especially in your digestive system, they're not allowed to do that. So you turn the vagus on and it quiets the T cells and it quiets the macrophages. But I thought you said we need macrophages. We do, but we don't need them to be off leash.
Right. This is perfect. And that's the 4 o'clock alarm going off. So
I have to remind everybody though, this is July 2nd. We have a 5-day core, July 16th through the 20th.
Go.
And I want everybody to come to Troutdale. We have one in Rome, we have one in Costa Rica, and I think we have one more or two more in the US, and they're all in Troutdale, and we have a great time.
Yes.
And I'm teaching them, and I'm reminding everybody, just so it's not a surprise in a year and a half, I'm not going to be doing them forever. The new generation is coming up that will teach them in person. We have me on video, But if you want to get the same old jokes and the same old,
OG core, you have to. Yeah, and Troutdale it's amazing just to see the clinic. I think that's like a very, like, it's an understated bonus is to see a clinic that has FSM implemented in it. So you can get a lot of really good ideas of when you get really inspired at the course, and then you're on the plane going home going, how am I going to use this? You can see it a little bit, you get an idea. And of course, it's time with you. And they have really good tacos underneath where the seminar is. And you said it, they might be they're just delicious.
and the Thai food down the street and the Italian food across the street.
Or you could imagine wanting, it's on that street. So it's a perfect location to see you in your element teaching. So everybody should go in July. And then they can come to Dublin and come to the sports course in September to see me.
And then we're setting the schedule up for 2026, and
Yeah.
you and I need to get our head together so we can put together maybe these 4-day weekends.
Yeah, I
We've
love
never
it.
done that before.
Makes a ton of sense.
Doesn't that make sense?
We get stuff done when we talk. Thanks everybody for listening to us plan out our year. But
And then, yeah, I'm getting excited about the afternoon lectures.
yeah,
I'm excited about getting to completely redo the advanced.
yeah,
But then the afternoon speakers in all sorts of stable state fields and adjunctive fields and
yeah,
all the things.
amazing.
Yeah. Oh, and Juliana Mortensen is publishing a paper, by the way.
Oh,
That's
amazing.
oh yeah. Oh, that.
And there's that. Yeah. All right, everybody. That is it. Lots of knowledge today.
And fun.
Knowledge and fun. It always goes hand in hand on these Wednesdays.
You got it.
All right. We'll see you next week. Bye, everybody. Thanks.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.